students, today we will continue your second unit Pharmacology of Drugs Acting on Cardiovascular System. Its first chapter, drugs used in the therapy of shock. So already we have studied the four parts of this chapter, and today we will study the last part of this chapter. In this chapter we will study today the distributive shock. Distributive shock. Distributive shock is also known as vasodilatory shock, is one of the four broad classifications of disorders that causes inadequate tissue perfusion. Systemic vasodilation leads to decreased blood flow to the brain, heart, and kidneys, causing damage to vital organs. In short, we can say the distributive shock is a form of shock in which severe vasodilation, despite normal blood volume, results in improper distribution of the blood flow. Then come to the classification and the type of the distributive shock. Here the type and the classification. So according to the cause, there are the three types of distributive shock. Number one is septic shock. Another is neurogenic shock. That is decreased sympathetic stimulation leading to decreased vessel tone. And the third one is called as the anaphylactic shock. Now, let us discuss about the first type of the distributive shock, that is the septic shock. This results from the sepsis. So, what is sepsis? Actually, sepsis is an abnormal body-wide inflammatory response to an infection that can result in death. Then come to the pathophysiology of the septic shock. In the pathophysiology of this septic shock, if any of the organism enters into the systemic circulation, is responsible for systemic inflammation or inflammatory response, which lead to diffused endothelial disruption and microcirculation defects, due to which there is a global tissue hypoxia and organ dysfunction, which becomes the cause behind severe sepsis. And this severe sepsis is responsible for multiple organ dysfunction and refractory hypotension, due to which a kind of shock is generated is called as the septic shock, and this is the pathophysiology of the septic shock. Now come to the clinical signs of septic shock. The first clinical sign of septic shock is hyperthermia. Hyperthermia is the main clinical sign behind the disease called as the septic shock. And another important clinical sign is tachycardia. And wide pulse pressure, low blood pressure, that is the systolic blood pressure less than 90, mental status changes. Then let us summarize the treatment of this septic shock. This septic shock can be treated by the fluid replacement therapy or by the use of the supplemental oxygen or by providing the supplemental oxygen to the patient depends on the condition of the patient with that of the fluid replacement therapy. Or with this, the use of different type of the antibiotics. Here the survival of the candidate correlates with how quickly the correct drug was given. Now let us focus on the important part of the therapy is to cover the gram positive and the gram negative bacteria. We are using the ceftriaxone 1 gram IV basin and imipenem 1 gram IV tisine dye. Additionally, to treat this septic shock, we are using the gentamicin or cefepime to cover the sepsis from the pseudomonas and vancomycin to treat the sepsis from the MRSA, that is the methicillin resistant Staphylococcus aureus. So that is the anaphylactic shock. Anaphylactic shock develops the following exposure to the allergen and cross links to the IgE on the mast cell, causing the mediator release like histamine and the eicosanoids, leukotrienes, prostaglandins. The clinical presentation of anaphylactic shock is urticaria, angioedema, bronchospasm, hypertension, and cardiovascular collapse. This is how the anaphylactic shock is caused. So how and why we can see here, IgE antibody has entered the body and bound with that of the antibody, and antigen antibody complex get bind with that of the mast cell, and that mast cell is responsible for the release of mediator like histamine, is responsible for the dilation and the oozing of the blood vessel and irritate nerve ending and the airway obstruction. So irritate nerve ending is responsible for skin itching, and dilated and oozing blood vessel is responsible for the fall in the blood pressure, and the airway obstruction is responsible for the cough and wheezing. So both of these things are responsible for the poor oxygen supply to the brain, and this is responsible for the anaphylactic shock. The approaches for the anaphylactic shock are the assessment like TRIDOR, can the patient talk, angioedema of the face, and the management of anaphylactic shock, and the racemic mixture of the epinephrine to give the primary therapy to treat the anaphylactic shock, and endotracheal intubation for the proper breathing. Here we illustrate the anaphylactic shock field management. Field management can be done by the recessor position, assess, help, adrenaline, auto injection, chin pull, head tail, and by CPR and up to the hospital. The assessment of anaphylactic shock is like the breathing assessment, respiratory effort is there or not, respiratory rate, wheezing, pulmonary edema, and the management. Ventilate as necessary. If it is required, provide the oxygen, pass oximeter, and sedation may be necessary for the ventilation after the intubation. And if we will talk about the treatment, the ephedrine is the first line of the drug, which is given the standard dose through the injection 0.5 ml in the ratio of 1:1000 intramuscular, repeated every 5 to 10 minutes. If not improved, the same injection 0.5 ml is given in the ratio of 1:10,000 if required. So the ephedrine, which is a showing alpha agonism, beta agonism, positive chronotropic effect, and is an absolute contraindication with that of the ventricular tachycardias. So it is given through the route and dose, like mild adult is given subcutaneously 0.3 to 0.5 ml, in a moderate adult given intramuscularly 0.3 to 0.5 ml, and in severe adult intravenous it is given 10 ml of 1:1 lakh ratio. The another drug of choice is the antihistamine, H1 antagonist and the H2 antagonist. In case of the H1 antagonist, mild, moderate, severe, and the repeated doses are given. And for the adult, cimetidine is 300 mg IV, followed by the 300 mg per oral, please every 6 hours until 3/7. Another drug is the bronchodilators. It should be added if the bronchospasm does not respond to the ephedrine, like albuterol nebulizer 2.5 to 5 mg, nebulize and repeat may needed continuously. Other supportive drugs are corticosteroids. Limited benefit actually as onset of action is 4 to 6 hours, blunting the late phase. Loading the hydrocortisone 250 mg intravenous or methylprednisone 125 mg. And another drug is the glucagon, that is showing the positive inotropic and chronotropic cardiac effect independent of alpha and beta adrenergic receptor, and enhances the CMP synthesis. In this manner, they are working. The another choice of drug is omalizumab. It's anti-IgE complex, circulating but not receptor bound. In special cases, this drug is used. Another type of the shock is the neurogenic shock. It developed secondarily due to a sudden loss of ANS function following the spinal cord injury, resulting in vasomotor tone and impaired cellular metabolism. The sign of neurogenic shock is hypotension, paradoxical bradycardia, warm and dry skin, and adequate urine output. Bradycardia is there due to the loss of sympathetic intervention, and hypotension is due to the vasodilation due to the loss of the sympathetic tone. Usually occurs with the injuries at or above T. Management of the neurogenic shock is made by the fluid replacement therapy, dopamine, vasopressin, and certain vasopressors like the adrenaline or epinephrine and the atropine. So today we finished the last part of the chapter, drug used for the therapy of shock. So thank you.